we have seen more cases outside Africa, and very soon many outbreaks in European countries, and therefore a public health emergency of international concern was declared last year in July. Before, as I said, the disease was mostly seen in Africa, but we had seen some sporadic exported cases in other countries in the world in the last decade. But those sporadic cases never made sustained transmission. And so really last year, it was the first time we had seen sustained outbreaks in other countries than in Africa. So far, we have seen this disease now in more than, in exactly 112 countries, more than 100 countries around the world, in all continents, and the virus continues to spread. Some countries have controlled the outbreak and are already thinking about another strategy, a strategy of elimination, and you will hear about it later. But other countries are still struggling with the virus, and the transmission is still ongoing, with even surges in cases in some places. So nevertheless, the public health emergency of international concern has been lifted in May 2023. But it doesn't mean that the fight is over. It means that we are still with this virus, and we need to find a way to deal with it, control it, and if possible, eliminate it. But what we have learned in the past year is two important things I want to highlight. We have learned a lot, of course, but these two things are for me quite important. First, we have learned that the world is very vulnerable for emerging diseases, because we have seen that a disease that before was localized can spread around the world in a matter of weeks and create outbreaks elsewhere. But we have learned as well at the same time that we have resources to overcome those vulnerabilities. And I think the communities and communities engagement is one of these important approach and intervention that we need to leverage when we are facing those emerging threats. The second thing I think it's important is that we have seen that for the disease where there were some tools for the response, vaccine, antivirals, diagnostics, we have seen, unfortunately, still inequity in access. Some countries access those tools very early on in the spread of the virus, and other countries still have not had access to diagnostic, vaccine, or therapeutic. So I think this is a very important lesson learned, because for the next pandemic, and we hope it will not be soon, it's very important that the world is better prepared to make sure that we can have a better equity in the distribution, allocation, and use of vaccine, therapeutics, treatment, diagnostics, and any other epidemics-related products. So with this, I will leave the floor to the panel of experts to introduce the subject and provide their perspectives, but also ask for your inputs. So over to you, Supriya. Thanks a lot.
Sylvie, some very key points talking about how the world among Mpox showed how the world is vulnerable to emerging diseases, and also the question of equity and access. So as we said initially, this is a consultation, not a presentation. So we would like your views. We now have a Slido with some questions, and we would like your views on this. Over to Rosamund. Please scan the QR code and respond to the questions. And I invite Rosamund to summarize the results. You give a few minutes for everyone to.
So as you can see, you do have access to Slido. The link is provided in the chat. The code, I believe, is Mpox. And the first question is, I am concerned about Mpox as a global infectious disease. And we have a number of people participating already. So on a scale of 1 to 5, 1 being least 1 being strongly disagree, right? So least concerned, and 5 being strongly agree. So as we are seeing people responding in the chat, we have a preponderance of respondents who actually feel strongly or very strongly about Mpox being an infectious disease that concerns you all. I think responses are still coming in, and we have responses in the chat as well. Thank you, Megraj Rajigriti, giving us a 5 for very concerned. So while we have seen a tremendous response to the global outbreak, people are still concerned, and we'll go through some of the reasons for that. Supriya, I believe we have a second question. So we have 2 questions to open, and we'll give you a few questions throughout this consultation.
Here's the second question. It's on your screen now.
So if you can't access the poll, it may be that we need to put the link in the chat again for those who arrived later. Can we kindly put the link in the chat one more time? So the second question, it is possible to address inequities in access to Mpox countermeasures. So we're acknowledging that there are inequities in access to Mpox countermeasures. And the statement is, it is possible to address them. So we have a group of optimists here who strongly agree that it's possible to address these inequities. Many people are giving us a 5, highly strongly agree with that. However, a number of others who feel that this statement may not be correct. So we invite you, as we continue through this whole consultation, there will be other questions, but if you would like to give an explanation for your response, either you agree with this statement, it's possible to address inequities, or you don't agree with this statement, please do put your response in the chat. We will, of course, later be downloading the transcription of the chat, and we will include your remarks, suggestions, comments, and considerations in the strategy that we are building. So I believe those were the 2 questions that we had for this part, just to open up, to whet your appetite, to see your level of interest. So strong interest from most those who've responded, but mitigated confidence that we can address the inequities. Okay, so I think back to you, Supriya.
Thanks very much to everybody for sharing your views on those 2 questions. So now that we hear your views, I invite Rosamond to provide an overview of what's being planned, the Mpox strategy for elimination and control. And as she speaks, and also as we go forward with questions with the panelists, please do share your views as well in the chat. And if you have questions, please put them in the Q&A section. Over to you, Rosamond. Let's hear from you.
Thank you very much. I believe Jiangfang is putting up the slides for us. Thank you. Thanks very much. Okay, so basically this will be a short introduction, because we do have a group of panelists who are keen to engage in conversation with each other and with you. This is the Global Strategic Framework for Enhancing Control and Achieving Elimination of Human-to-Human Transmission, and a very lofty and ambitious goal. Please go to the next slide. So this is just a background. I only have 1 slide on this, that we as WHO did undertake a survey of member states. All member states were invited to respond. You may be aware that there are now 89,000 cases confirmed and probable cases reported to the World Health Organization from 112 member states. We've had 2 new member states just in the last month. So this virus is clearly still on the move, even though there has been a tremendous global response to the outbreak. So the purpose of the survey, which was undertaken just in the last month, was to assess the presence of a national strategy for Mpox outbreak and implementation of WHO temporary recommendations. As this was a public health emergency of international concern with an emergency committee, the Director General did on 5 occasions issue temporary recommendations to member states, which is under the IHR, under the International Health Regulations. And although the emergency was lifted, in fact, the current set of temporary recommendations are still in effect and still valid. You can find them on the website, or we can put it in the chat, where you can find the current set of temporary recommendations. They are valid for 3 months at a time. So the main domains that were covered were whether countries do have a national strategy and some of the elements that Sylvia already mentioned: risk communication and community engagement, of course, surveillance epidemiology, clinical management, and access to antiviral therapeutics and vaccines. What you see here in the graph is the number of countries that responded. Remember that regions in WHO have different numbers of countries in them, but we've had a tremendous response from Euro, CRO, actually, I believe all the countries responded, and a reasonable response from the Americas, the African region, about a third of countries, and so on. So of the 77 countries responding, 93 responding to this survey, 71 reported that they do have a national strategy. So that's pretty good for an outbreak that did not affect everyone nor all countries, but really there was tremendous engagement worldwide. So most countries have a national strategy, including countries with no reported cases. The European region, most completing the survey, the countries there have immunization strategies as well. So we'll come to that. Access to vaccines and therapeutics otherwise remains low in some regions. And countries are already beginning to integrate Mpox preparedness and response with their HIV and STI and other programs. And some countries have activated One Health coordination. Next slide, please. So our goal for the new strategy, we do have a strategy in place until this Friday. It is the current Global Strategic Preparedness and Response Plan, and it will be replaced by the Global Strategy for Mpox Control and Elimination of Human-to-Human Transmission. So the goal is to achieve sustained elimination of human-to-human transmission of Mpox, and the objectives that you see there are to control Mpox in every context, to reduce community transmission, to minimize zoonotic spillover events and transmission, and to advance Mpox research and access to countermeasures. So this is the current status. In the strategy, we're proposing a description of different contexts, and we feel that virtually every country can find itself in these contexts, and that within large countries, of course, there may be regions that are in different contexts. So it's not that there's one context per country, it's just that in any area at supranational, national, subnational level, there may be different epidemiological contexts. So the first one is areas reporting sporadic cases or sustained community transmission, primarily, but not exclusively linked to sexual transmission among men. This is what the global outbreak has consisted primarily of, but again, not exclusively. We have areas with mixed modes of transmission, continuous over time, in which cases are more distributed among men, women, and children, with known or presumed person-to-person transmission. West Africa, Nigeria in particular, would be a good example of this context. Episodic or recurrent outbreaks, often in rural areas, involving both person-to-person transmission and potentially linked to zoonotic spillover events. That would be Central Africa primarily, but also East Africa and parts of West Africa. And many countries have no reported cases, including consideration of areas from which travel-related cases are reported elsewhere. So we have some countries that have no cases, not reporting cases, perhaps not detecting cases, but other countries are saying we have a traveler with Mpox who has come from that area. And so we are appealing also to all countries that are not currently reporting cases to either report the cases that they have or to undertake investigation at source of travel-related cases elsewhere. Next slide. So for the strategy, we have a broad approach, which is to know your epidemic, know your risks, know your community, know your needs, and of course, take action. So with respect to this specifically, we've already mentioned that collaboration is necessary to enhance context-specific surveillance and understand who's at risk in your community. And this can be at the individual level, the community level, or the global level. And as already been mentioned, engaging with the community that's at risk is critically important, and therefore it's important to know your community and to know your needs. Needs need to be quantified. So, for example, if we're talking about equity to vaccines, equity for access to therapeutics, countries or regions or even community groups need to support the assessment of what is needed, because without quantifying your needs, it's also difficult to put in a request that makes sense. wherever for support, whether it be a community level to the national level or from national level to the global community. And of course, the strategy is all about taking action. For the guiding principles, we're also proposing that all response should be context appropriate and in some measure community-led, that all persons at risk should have equitable access to stigma-free, non-discriminatory, safe and confidential services within a continuing global effort to expand access to medical countermeasures. So respect for equity and human rights is essential. That programs should be integrated as much as possible to ensure their sustainability. Surveillance, prevention, diagnosis, treatment, and care for Mpox should be integrated within existing programs, services, and health settings with close coordination, for example, with HIV and STI services, but not exclusively, and certainly with One Health approach will also be important, and that everything we do is evidence-based as much as possible, and the more we engage in continuous learning, research, and evidence generation, the better our response will be. Next slide, please. So this is just to illustrate that where we were following the fourth emergency committee meeting, which was in February, that we received as WHO concurrence and guidance to continue technical work and strategic work in this direction, which is to maintain surveillance, integrate Mpox response with HIV and STI programs, continue to strengthen capacity, including in our CCE, to implement a broad and comprehensive research agenda, and to enhance access. We were also guided that countries need to develop their own Mpox control and elimination plans according to their national context. Next slide, please. So basically, in this new strategy, we are continuing with the health emergency preparedness and response architecture that is in the current strategy, which is available online, which has been guiding us through this whole response for the past year. And so we will continue with recommending to countries emergency coordination. And you see that this can cover a number of different areas: collaborative surveillance, which includes event-based monitoring, case investigation, contact tracing, wildlife, wastewater surveillance where appropriate, and of course, laboratories and diagnostics. As I speak right now, in the room next to me here in the Emergency Operations Center of the World Health Organization in Geneva, there is also a concurrent meeting, which is updating laboratory and diagnostics guidance for the Mpox response. It was first released a year ago in May 2022, and that group is currently updating the surveillance guidance. So you will continue to see a new and fresh guidance coming out of WHO based on evidence that is being generated by clinicians and communities and scientists all around the world. The third one is community protection, which includes risk communication, community engagement, public health and social measures, immunization policy and strategies, and access to vaccines. Of course, clinical care is always there for an infectious disease, and infection prevention and control, and then access to countermeasures specifically, as well as research in a broader research agenda. Next slide, please. So that is how the strategy is presented. It's presented in the Health Emergency Preparedness and Response Framework, which you have already seen in the current Mpox strategy and in the recently released COVID-19 strategy, following the same framework, so that stakeholders can begin to find themselves that some things look familiar and organize their response capacity accordingly. But what do we mean by control and elimination for what is, remember, not an eradicable disease? This was a zoonotic disease at source. It remains a zoonotic disease in some places, and therefore we are not talking about eradication. We're talking about control, and we're talking about elimination of human-to-human transmission. So control of Mpox is the absence of new Mpox cases beyond 6 weeks. This is a proposal. It's not written in stone, but it is a proposal based on 2 maximum incubation periods. Generally, the incubation period is 5, 6, 7, 8 days. Around 7 to 10 days. Of course, it varies. It depends on the mode of exposure, and it depends on the person who is ill. But we've seen some extreme examples of very long incubation periods, but the vast majority, if they're going to manifest illness, they manifest within 21 days. That's 3 weeks. So we've chosen 2 maximum incubation periods. This is similar to what is done for Ebola. And so again, we're trying to also provide a strategy that resonates with people who are already working with certain diseases and may recognize certain features of the strategy. Community transmission of Mpox is the presence of Mpox cases transmitted via human-to-human contact for more than 6 weeks after the first reported case. I seem to be missing the definition of elimination in here. Elimination, what we were proposing is that if, for example, there's a travel-related case, there may be a small outbreak related to that. But if a country has managed to go 3 months without a case and has stopped the outbreak, no cases for 3 months. It's a short period of time, but in this first iteration of the strategy, we're proposing that it would be 3 months to determine elimination, because we know this is an infectious disease, but it's not the most infectious disease. It transmits through close contact. And so there are intervention measures that are possible. So one question to you, is this 3 months long enough to determine elimination? If we take the measles analogy, measles elimination is defined that there are no cases of measles. If there's an outbreak, the country or region has 1 year, 12 months to stop that outbreak, and they don't lose their elimination status. So we're also proposing, by analogy to measles, that if within that 3-month period that there have been no cases at all, that a travel-related case is imported, or a zoonotic spillover event only leads to 1 or 2 additional human cases, then the elimination strategy does not have to be, the elimination status does not have to be lost because it's demonstrated capacity to detect an outbreak and stop the outbreak, and therefore still in elimination status. So these are all suggestions for discussion. Next slide, please. Oh, sorry, just before you go, minimizing zoonotic transmission is the active pursuit of One Health policy strategies, interventions, and actions to reduce the occurrence of zoonotic spillover events. So acknowledging we need to learn a whole lot more about how Mpox manifests in animals, how the monkeypox virus transmits in animal populations, and more about the reservoir. For example, we don't know much about the reservoir. So next slide, please.
Rosamond, can you just try wrapping up a little bit?
Yep. Okay. So I wasn't going to go into detail on these levels. It's just to illustrate that we are that we have these levels that we're proposing: elimination, countries that have not been affected, control. Next slide, please. Couldn't fit these on one slide. A country may have an unknown status, or community transmission may be clearly still occurring. Next slide, please. So this is it. So the strategic framework and a complementary country planning guide will guide action with practical steps and milestones to develop national and regional plans to enhance control, minimize zoonotic transmission, and achieve elimination. Ensure that all regions and member states have preparedness and response integrated into relevant health programs, and strengthen and support links to achieve progress at every level. And that's it from me. Thank you.
Thanks, Rosamond. Without further ado, I'll quickly go on to some questions for our panelists, because I know Meg also has other commitments. So firstly to you, Meg, effective communities have played a key role in addressing the multi-country outbreak in 2022. In your opinion, what lessons from this response should be amplified and applied to the long-term goals of Mpox control and elimination? It would be lovely to hear your views, and then maybe Andrew could add as well.
Yes, thanks so much. And I really appreciate the opportunity to join in, and sorry to rush along the team. I think we all these days have many agenda that we have to join. But in particular, I thought this was very important to join this session because based on the last slide that Rosamond put up, we do have to prepare for a time and a space where we may not have the emergency response. And at least for human to human, which has been primarily, as we saw in this multi-country outbreak, transmitting through sexual contact, that we do want our HIV, hepatitis, and STI programs and strategies to be considering Mpox as part of that work. And just to note from the very beginning, our department and our team of HIV, hepatitis, and STI were brought into this outbreak because particularly to bring in some of the thinking around clinical care, but risk communication and community engagement. Because for many years, 30, 40 years, WHO and HIV community has had people who are affected with the infection and the disease at the center of the response, and certainly has taken their lead and their guide from communities and civil society members. And community writ large as the group that needed to be there right from the beginning, because as this became a fake or a public health emergency of international concern, the stakeholders were ready and willing to provide us with a voice to bring together a group who were able to immediately review documents, review technical guidance, to look at the language, to ensure and advocate for equity, and to engage in actually the responses at country level in their communities and ensure that their leaders were aware of what global work was happening and what regional work was happening, and to share that information. And to share that information in modalities that perhaps public health experts don't have access to, might be dating apps, other community interactions. So we really relied on our community and stakeholders who brought those messages to the world, and we think helped craft very comprehensive and engaging and also inclusive messages. So for this new strategies, lessons learned, I would say, and what we need to do as we move forward is that all communities, whether in high income, low income, from Latin America to Africa, that the messages need to be targeted towards the community, developed by community, amplified by community, but then also at the same time linking to resources. And I think those resources are definitely part of where we need to learn for the future as we take this new strategy forward. One area where we believe in the long term, communities and stakeholders need to be at the table is providing values and preferences around our guidelines and recommendations. And as you saw the first or second slide, I'm an optimist. And I believe that we can bring the interventions to the communities who've been left behind. And I would say, we know that there's communities in Latin America and Africa who have been left behind as of right now, and that with their help and with their engagement, we can take this global strategy, create regional and country strategies where communities should be at the table, like they have been with our HIV work, and that they're ensuring across all the pillars, whether it's risk communication, whether it's surveillance, clinical engagement, IPC, and certainly the availability and access to diagnostics, vaccines, and therapeutics, with their advocacy, with their communications to leaders that will be able to bring forward a more equitable response. I've also been asked that going forward for pandemic preparedness, how do we take the lessons learned from the response to Mpox, the response to HIV, what we're doing now with STIs and hepatitis, and have communities who are available, who know the language of public health, who are ready and willing to take on this work, and ensure that every time there is any kind of new outbreak, new pandemic on the horizon, that this is not something that has to be developed anew, but it's there and integrated and part of the response from the beginning. And even though this may not be the most easy marriage, and we've seen with COVID that there can be widely different views from community, but having those views available to help craft your messages and learning from those messages and what is happening will ensure that we're successful as we move forward. So those were a very brief elements of my thoughts here. And I have to apologize because I do have to step up, but Andy Seal, who works with me and has been involved in these EPI-WINs, will answer any future questions. So I really want to thank you very much for having me here. Thank you.
Thank you very much for joining us, Meg. I really appreciate that you could join even for a short while. Over to Andy. Would you like to add to what Meg said?
Thank you, Supriya. Hello to everybody. Yes, really just to build on a few things and expand a little. So this year we're celebrating the 40th anniversary of really the start of a concept that's really defined a lot of the work that we do with communities in public health. And it's the 40th anniversary of the Denver Principles, which were the first principles to describe the meaningful engagement of people living with HIV that have really been at the heart of the response to HIV since the beginning. And this principle has been expanded. It started within groups of gay men, a little bit along the lines of what we saw with this Mpox multi-country outbreak, but was very quickly also taken on and really informing the responses across Africa, the other part of the world that was very affected by HIV in the early days, and in all communities impacted by HIV. So I think this principle needs to be unpacked, and I think it goes beyond a little some of the things that Meg talked about. I think we need communities engaged very early. We need them engaged in strategic oversight as well as in values and preferences and in messages. And they really have tremendous value in informing us as public health people about how best we organize ourselves, what we prioritize and how we really phase our approach to this. So this is whether we're talking about gay men and other men who have sex with men in all regions of the world and in all of the contexts that were shown by Rosamond, or other communities. So, for example, the communities in West Africa where we see zoonotic and human-to-human transmission occurring. So recognize these are very diverse groups. Within those diverse groups, you will have communities that are organized around potentially HIV service delivery, for example. These are your core people. Look for these people, engage them. They understand health, they understand disease transmission and dynamics, and they've got years of experience. And we, in situations like this, we're all learning together. So create that environment of trust and learning and sharing, but really bring the communities in. If in your context, it's possible to also recognize ways to compensate communities, do it early as well, because we saw in COVID, we saw in Mpox, a lot of people from other health areas are diverted, and it takes quite a bit of time to recognize the disruption to the other areas that they're working on initially. So let's try and make sure that we're doing that. With this outbreak, we've also seen considerable overlap with HIV. So a significant number of people presenting with Mpox were also HIV positive, or they were using pre-exposure prophylaxis as a prevention option for protection against HIV. So these communities are accessing health services, and it's these health services that we've already seen from the presentation that are well placed to take forward this integration approach moving forward in a non-emergency context. So I think we've probably got other speakers lined up. There's lots more I could say, Supriya, but I will hold off in the interests of the rest of the program. But feel free to bring me back at any point. Thank you.
Thank you very much, Andy. Well, the key message, build an environment of trust and bring the community in. So with that in mind, building trust, I move on to a question for Dr. Sylvie Briand. My question to you is about access to countermeasures. So improving access to countermeasures, including tests, treatment, and vaccines, is crucial, not just for Mpox, but for all global disease threats. What are the top steps to be taken, and by whom, to improve access to Mpox countermeasures in the next 12 to 18 months? So Sylvie, you have wide experience of a number of public health emergencies. Over to you.
Yeah, thanks a lot, Supriya, for the question. And I think for Mpox, one of the challenges we faced was that it was a new disease. And so there was, in theory, no treatment, no vaccine, and no diagnostics, or there was some diagnostics, but in a very limited quantities, because, as I said before, it was limited to certain countries in Africa. And there have been outbreaks, but there was the management of the outbreak was more based on public health and social measures rather than using vaccines and therapeutics. Although there was some studies ongoing in those countries to see if some vaccines and therapeutics that are used or that were developed for smallpox could be used for monkeypox. Because in reality, what has happened since the eradication of smallpox is that the countries in the world have continued to develop products to control smallpox should the disease reemerge. Unfortunately, since its elimination, its eradication in the 80s, smallpox has not reemerged. But many countries, scared by the possibility of reemergence, had developed new countermeasures, and namely new vaccines and new antivirals for smallpox, and have kept this in reserve in case there could be a reemergence. But of course, those countries are only a few countries, and countries, wealthy countries who can afford to have stockpiles of things that may not be used for a long time, or maybe never used. So what happened when this Mpox outbreak started is that the drugs and vaccine we had were unlicensed, meaning that they were not on the market and not approved. And so suddenly, I mean, in the first countries affected, where they had national regulatory authorities, then they approved the drugs and vaccine that were developed for smallpox, but gave a special approval for monkeypox. So this is why some countries have been able to use those vaccines and those treatments for their communities that were affected at that time. But it was not the case in all countries, because first, some countries don't have national regulatory authorities, so they couldn't approve those drugs and vaccines. And so it was really difficult for them to also buy or supply and procure those drugs and vaccines, because in the absence of national regulatory authorities. And secondly, because it was unlicensed, there is not really a market for it. The production is in very limited quantities. And so, as you know, when something is not, it's rare, then it's expensive. So many countries also couldn't have access because of the price of the drugs and the vaccine and the limited quantities. So I think what is really important is first, when we have this kind of emergence, is first make sure that the drug we are using or the vaccine we are using are not, don't have a major adverse effect, they are safe. And this is really what is important. And that was when they were used initially in some countries, it was not used like that. They were used with special protocols where a lot of information was collected to make sure that those products are safe. The second thing that was important is wherever it is used, we can continue to collect data, because the drugs or the vaccine may have different impact or adverse effect in different communities. So it's very important that we can conduct those research to make sure that those products are safe. But again, conducting research is sometimes extremely complex in emergency. It may also be very difficult in certain settings, because you don't have necessarily the diagnosis, you don't have necessarily the capacity, also the workforce to conduct research, because it's of course obviously more cumbersome than just providing care. And so we have faced a number of difficulties especially in low and middle income countries to set up those research protocol, to conduct those research studies, and so to make sure that the vaccine and those therapeutics are safe and efficient. So I think for the lessons learned for the future is first that we need to first strengthen capacities in low and middle income country, regulatory capacities, or find mechanisms so that they can have the capacity to authorize the use of those drugs. Second, really coordinate better the access and allocation at global level so that it's faster and also more timely, obviously, and also that countries in need can access those drugs really when they need it. And third, making sure that we have in place a mechanism also to ensure either tier pricing or transfer of technology whenever it's possible, so that we can have more quantities and at an accessible price as well for the countries in need. So there is a lot to do, in fact, to make sure that we overcome this inequity. And everybody has to work on it. It's WHO, of course, but also countries, making sure they have the regulatory pathways in place and the ways to procure those drugs in a timely manner. But also partners also helping us to convey the message of equity. That, of course, will be very useful for this. And I will put on the light because there is a storm coming in and it's becoming very dark here. So sorry for that.
Thank
Yes.
you. Go on, Rosamund.
No, I was just going to say, poor Sylvie, you seem to be sitting in the dark already over there. But thank you very much. I go back over to you, Supriya.
Thanks, Rosamund. And yes, thank you very much, Sylvie. Very pertinent points talking about lessons learned, improve regulatory capacities, timeliness, and the need to coordinate better, and technology transfer, tier pricing, as well as, partners, the role of partners. Thank you very much, Sylvie. Would you like to add anything more to that, Sylvie? I wasn't sure whether you finished or whether you just got off to put on the lights.
No, thank you. No, I think it was fine and you summarized it very well. And I'm sorry, I should have lighted it before, but before there was a bright sky with sun. And so I thought it was okay, but it's not okay. But thanks a lot and happy to answer other questions. Although I will have to leave you for another meeting very soon, but I'm sure that Rosamund has been part also on this process, but I just to highlight really that we would like really to do research in emergency because it's very important for unlicensed product to gather the data that we need to ascertain that those drugs are safe and efficient. But really, I think it's very hard for certain countries to carry out research projects in emergency because already in emergencies, they need much more health workers to do just the care and all the surveillance and all those public health activities. And so it's very hard for certain countries to mobilize additional workforce to do research. So I think this is something that should be taken into account for the next pandemic as well, because not everybody can carry out those things. And maybe we should look at different protocols, research protocol, maybe engaging more communities again to help to collect data and having a research that is not done necessarily only by experts, but also by other people who could give a hand in emergency. So that was it. Thank you very much.
Thank you, Sylvie. Another very important point on research there. Rosamund, would you like to add something there as well? Before I go on to the next panelist.
I do think it's been covered very well. Just one possible additional remark is that everyone is very concerned about access to vaccines, for example. And in the global outbreak, it was relatively quick to identify who was most at risk. And therefore, offering vaccines to where it was available, to contacts, to people at risk, to health workers that may be exposed. These are things that could be done by countries with vaccine, of course, but also able to identify their risk group. So that identification of the group at risk is really critically important, because this is not a vaccine. Mpox vaccines are not recommended for mass vaccination. We are absolutely not in a situation of offering Mpox vaccines for routine immunization for children, nor for mass vaccination. Therefore, equity also relies on the ability of the national authorities to identify the group at risk. And that is much more difficult in some places. In places where Mpox affects men, women, children for different reasons in different contexts, and health workers and laboratory personnel, it becomes really important to really know your epidemic, know your community, know who's at risk, and therefore then be able to offer countermeasures. It's not a simply one size fits all, everybody gets vaccine and everyone's vaccinated. For this disease, it can't work that way. And so understanding the community, understanding the risks, and understanding the epidemiology actually becomes even more important.
And Supriya, if I can just add one small addition to that, you know, we're dealing with the multi-country outbreak has obviously impacted gay, bisexual, and other men who have sex with men considerably. And we shouldn't think that just because we've identified that category as a risk group, that's job done. There are multiple inequities within that group. And this is what we've really heard from our experiences in the last year. So, for example, men of color in the US were much less likely to be accessing vaccine than their white counterparts of the same age. And also, you know, people with refugee status, different backgrounds. So the usual intersectionalities that we look at when we try and understand health inequities, we need to apply them to smaller groups and recognize that within that those inequities will still be there. And that's critical. And the communities are the best place to help us with that. Thank you.
Thank you, Rosamond, and thank you, Andy, for saying that inequities within inequities and taking note of that is very important. Now I go on to the next question. We know, of course, even in a multi-country outbreak, there are unique challenges in different parts of the world and in different regions. So I'd like to invite our regional colleagues to share their views. First with Dr. Thibault Traoré. So Dr. Thibault Traoré is Technical Officer for Emergency Preparedness in WHO Regional Office for Africa. So the Africa perspective, what are the most important steps for countries in the African region to take now to respond to the emergence of Mpox in their context, whether due to local outbreaks or the global outbreak? You know, you've been through it. What do you think now?
Okay, great. Thank you very much, Supriya. And I think the previous speaker as well to set the scene. While I was listening to them, I just saw a message popping in saying that Cameroon, Southwest Cameroon outbreak. But that tells you already the local outbreak is not over yet in the region. So, but if you step back a little bit to look the data collected from, I have Felix with me here, who is tracing the data from the country as well, and he can step in at any time. Since January, 1st January 2022, and as of 19th June, but today is the 28th July. So just look at 28th, look at 19th. So the data collected is almost indicate that 1,741 confirmed cases with 21 deaths. But those data don't include the suspected cases from some countries like the DRC. If you look at suspected cases with Rosamond, we have looked at those data, over 4,000 suspected cases. Well, that's a serious concern. But having said that, the region will continue supporting countries with technical finance and financial partners as well. I think everyone is involved to strengthen their capacity in terms of surveillance and even laboratory diagnosis as well. And the environment is really good for that. The reason I'm saying that, given the different initiatives and especially the flagship project we have, I will name them as we go on. And we do have as well the strategy and guideline for this integrated disease surveillance guideline, which is adopted by all member states. And that in that guideline, you do have a substantial component for One Health approach, especially the third edition, and the community engagement, participation, and building the trust, especially what Andy was saying as well. And without that, it won't be possible to stop this, the ongoing outbreak or reemergence of Mpox. So the global strategy really come on time, because based on the global strategy, we develop the regional guidance notes. And that guidance note contain all the elements Rosamond presented. And it addresses the coordination, where we're going to focus on the One Health approach, not only at the national level, even at the local level. Especially, it's good for even DRC, the Democratic Republic of Congo. The reason I'm saying that is they do have a national One Health platform, and they are decentralizing the One Health platform to go to even the subnational level. And I think with community leaders' participation and community really engagement to address all zoonotic diseases, including Mpox, which is a great opportunity. So, and to stop the transmission of Mpox among even rural or urban area, the trust need to be built, and especially risk communication and regional strategy has been developed to address that one. Mpox is a part of it, but other zoonotic diseases as well, and the strong advocacy as well in terms of sharing information, which those are part of, and resource mobilization, all are part of coordination. So you set that coordination at the national level, but it will be duplicated or reproduced even at the local level. And enhancing surveillance and laboratory diagnostic laboratory capacity is really essential, because that's where surveillance is the key to disease control. Disease control, disease elimination, surveillance is the key. You don't have data, then you will be based all your decision on just, it won't be based on the evidence. I'm not saying you don't do anything, you do work, but really it is essential. So integrating Mpox, especially this strategy, and into the existing strategy in the region, strategy for health security, which will go up to 2030, 2022, 2030, and the different flagship. One is PROS, strengthening, promoting resilience system for emergency, which is the PROS, based on preparedness. You prepare country to support the country to get well prepared, and to strengthen and utilizing your response group for emergency. And you go to the rapid response team. It will cover Mpox. It will cover all health emergency. Just if you go to the website, you will see the bulletin. Mpox is among those diseases we are monitoring in the region. And every year it is almost 100 events, but a health emergency issue. So Mpox, it is included in it, and the strategy will help as well in terms of that area. So we continue for risk communication. I spoke about coordination, surveillance, and lab capacity, and risk communication. All member states, especially those affected, have developed their strategy, response strategy for Mpox. But the global one and the regional guidance document will just strengthen. In case there is, what do you need to do? So we will support them, we will continue to support countries to increase, to strengthen the risk communication and community engagement, building the trust. If the trust is lost in some countries, and you can still, with the community, with the skill, especially One Health approach, to include them, to see the benefit of it, you can increase that capacity. And there is room for improvement. And we work with colleagues from HQ and other region as well to strengthen that one. And so there is a guidance document developed by country. When we were developing the readiness checklist, especially, they developed the plan already. And case management as well, the regional office and country office with the support of HQ and other region, they will ensure that early recognition and treatment for all cases will be addressed. And the special case detected through the event-based surveillance or even indicator-based surveillance using IDSR. These are really a powerful tool and guidance document. The region will continue to support member states and to identify and treat all possible cases. And all those suspected cases we talk about, we document, we publish on it as well. And there will be system to strengthen laboratory capacity, whether using even mobile lab. And again, in the project and surge and tasks, you will see them. It is well outlined. That will be used as well. Mobile lab capacity to increase genomic surveillance, and those will be really crucial for Mpox and other disease, because we deal with several diseases and we know the health system is weak, but with the initiative, however, with the initiative we have in the region and the usefulness of collaborative effort the world has seen dealing with COVID and Mpox, all this will be part of our strategy to engage member states, and to strengthen the capacity to deal with local outbreak, whether it is in a rural area or the urban area. At the same time, to strengthen the research at the human-animal interface and environment. We have seen that now with our partner FAO, for example. We are working in WOHA, World Organization for Animal Health. We're working even in the DRC. We conducted joint risk assessment, and FAO is supporting the research at the wildlife interface, and you see, and so this issue and vaccine availability, of course, is a challenge in the African context. But we are negotiating with donor and vaccine producer as well. Those will be addressed as we go along. So in a nutshell, the context of Africa is different for what you will see from the next speaker from Europe, for example, where in Africa, the weak coordination, but with the ongoing initiative, we will address those one in the strategy to encourage the country to update the plan, the response plan, the preparedness plan, and the surveillance, which is inadequate, and information sharing. You have seen that on the first paragraph. I just describe the epidemiological data. The information is not shared on time or not enough, but with, again, with our ongoing effort and with our regional partner, we will address those ones. I give you just one example. For example, 717 a project with Resolve, our great partner, and those will be to address really all those all ongoing outbreaks to come in the future. And so the lab capacity, human capacity, that will be addressed, and
thank you very much.
Which is where now it will be addressed as well. So for the training capacity, I will stop here soon. The training capacity.
Thank you.
I didn't tell you
in the interest of time.
Okay. For the training, the Open WHO is available for all member states. Mpox, and it did not start from this global outbreak. It started before, and Rosamond can witness that one. And that we will use, it is open to all member states. IDSI again is open, and there are other training, and you will see with flagship project, surge project, for example, is empowered member state for rapid response. Really, so I will stop here. So no, otherwise you're gonna cut me off. Thank you.
Thank you very much. You both very important points that you've made, and I'm glad you highlighted Open WHO as well. But I hear, coordination, collaboration, some very important points in across all the different issues and pillars for response in the future as well. With this, before we go to a completely different region and probably a different perspective, we would like to get all the participants' views as well with another Slido. Now that you've heard Rosamond, you've heard Thibault, you've heard Sylvie and Meg, let's go on to hear your views. There you go. Thank you, Agnesi.
So, hi everyone. So again, we have our Slido questions. Please, can you kindly put the Slido link back in the chat for those who have joined us later? They may not have seen the earlier link. This question is: classifying Mpox as a sexually transmissible infection increases the risk of stigma and discrimination associated with the disease. Is that a statement that you agree with, or a statement that you may not agree with? So we're seeing right across the board responses that people don't agree with this statement, that classifying Mpox as a sexually transmissible infection alone is not enough to generate stigma and discrimination, but we have a preponderance of respondents who think that classifying it as an STI would increase generation of risk of discrimination and stigma. So we will have Andy, who's still with us here, maybe comment on this question as well. Supriya, should we do that now, or should we go to the next question and then open it up for discussion?
Let's open it up for discussion after the next question.
Okay, so keep this question in mind about whether STI, classifying Mpox as a sexually transmissible infection can lead to stigma and discrimination. Keep that in mind. You've seen the responses. And the next question. And thank you for your tremendous participation in these polls, by the way. I'm seeing the numbers and I'm very impressed. Okay, so the next question. It is important for all countries to address the emergence of Mpox, regardless of the region. WHO divides the world up into 6 regions, by the way. We have 6 regional offices with almost 200 country offices, actually 200 member states, sorry. We have 193 member states, and many of those, except in Europe and North America, also have country offices. So we have seen Mpox in all WHO regions, all 6 WHO regions. We continue to see cases in all regions. I'm not trying to influence your response here at all, but the question is, it is important for all countries to address the emergence of Mpox, regardless of region. There are many countries that are no longer reporting, by the way. So this in our past data that was released yesterday, we found that 20 countries have still reported in the last 21 days. So this is still a virus that's circulating. Okay, so we see a preponderance of responses here in the agree that it's important for all countries to address the emergence of Mpox. Over to you, Supriya. those who don't agree, by the way, please do tell us why in the chat. We will take all your inputs. And if you do agree, also tell us why in the chat. We will take all those inputs as we continue to finalize the strategy.
Thanks, Rosamund. So, Andrew, over to you. What do you think about the response?
Thank you. I'm slightly surprised, but at the same time, I'm not. I think, first of all, Mpox, we know Mpox is associated with sexual transmission. So that's a fact. And that in itself, that association, regardless of classification, will generate a level of stigma and discrimination. So however we move forward, we need to be very sensitive to stigma and discrimination around Mpox, because whether it's classified as an STI or not, it is linked to sexual transmission. We know sexual activity is a very effective way to transmit Mpox. And so we're going to have to build in very thoughtful, programmatic approaches around stigma and discrimination, again, working with communities. Now, the issue about whether we classify it as an STI or not becomes interesting, because I think the question there is about, if we do that, does it unintentionally rule out the understanding of Mpox also being transmissible through close-to-close personal contact and through animal-to-human contact? So I think the issue is slightly complex. I think it's a good question because it teases these issues out, but I do think that we need to be mindful that whenever we're communicating about Mpox, we need to be very clear about what the key modes of transmission are for a particular community that's affected and what the additional modes of transmission might be. So it's absolutely, we need to continue to be saying, that Mpox is not just transmitted through sexual contact. We've seen that in the multi-country outbreak. We've seen household contact where perhaps the primary, the introduction of Mpox into that household was sexual, but then household internal transmission was not. And so we have to be very sensitive to that. But at the same time, we need our STI services and we need our STI responses to be alert to this, to be able to respond to this. So I think it will, in some ways, require a contextual and localized response in terms of how transmission is communicated. At the moment, we don't, WHO doesn't describe it as a sexually transmitted infection, but we emphasize the sexually transmissibility of Mpox. And I feel comfortable with that position because it does allow us to have this slightly more nuanced explanation that I've just introduced into the chat here. Hopefully that helps. So we need to be tackling stigma and discrimination for all aspects of working on Mpox, including around perhaps over-association with certain groups, for those groups that are affected, but also for groups that might feel somewhat hesitant in coming forward for fear of identifying with those groups. We have to recognize that this is a complex and dynamic space and be sensitive to how we work in this space. Thank you.
Supriya, may I add to that one?
Yes, please do.
And I think maybe Tieble would like to come in on this one as well. Stigma and discrimination are not limited to specific modes of transmission or specific population groups. I have here in the room with me my colleague, Dr. Adesola Yinka Ogunle from Nigeria, who led the first Mpox response there in the first years of the outbreak in 2017, 2018. It was very clear from the very early days that discrimination and stigma are linked to also just disease in general. Anyone who is ill, anyone who is handicapped suffers stigma, discrimination. Anyone who has lesions on the face, regardless of the cause. And so simply thinking that stigma is linked to sexual transmission it's a factor, but it's not the only factor. People are afraid to go out in public, and they shouldn't, perhaps, if they're having an infectious disease. But I'm just saying, people may even be left with sequelae such as depigmentation or scars, and still suffer stigma even after they have healed their lesions and recovered from their illness. So basically, the message from WHO is stigma is never okay. Stigma is not okay if it's related to illness, if it's related to handicap or disability, if it's related to visual signs of a condition, or if it's related to modes of transmission, because it also discourages people from seeking care. So if people also are afraid to seek care and support and assistance, then they will not be helped, but also transmission may continue in the interim.
That's a very important point. I mean, Tiable, would you like to add to that as well?
Hello? Yes, Supriya. Well, I think our colleague have said really the crucial part of it. But what this outline for everyone, even whether panelists or those participants, here is the need for research. Again, the reason I'm saying that, we don't know everything yet. And for the transmission, the mode of transmission, lot need to be done in that area. And so even the human behavior to those who are affected, it is not clear cut yet, because stigma can take different form, and the behavior to those who are affected by any kind of infection or pathology, whether it is genetic or it is acquired, really it is a serious problem everywhere in the world. And for such a reason, I think for the transmission, the mode of transmission in the African context, there is a need for a lot of research to be done. And now the team, different team, working on it. I think we got a team from Canada. They will work with colleagues from Nigeria and DRC to address some of the issue which we don't know about the mode of transmission. And then I think Rosamund knows that because she's been involved in it. And so these are really, there's still a serious question to be addressed. It's not only Mpox when it comes to disease again. Even your physical look, you can be discriminated by it, whether it is disease or not. And we have seen a colleague who posted recently about one of the pathology, which really bothered a lot of people. They've been discriminating in the society. And so for such a reason, and that will create a stress. And that stress will reduce even the immune system to be more exposed to pathogen, whether it is the Mpox, and to even get super spreading for the disease. So for such a reason, it is really important to look at it on that aspect. That's it. Yeah, thank you.
Thank you so much, Tribal. That's a very important point about understanding more research as well. With that, we go over to Richard Peabody, and welcome, Richard. I know you had other commitments and could not join at the beginning, but we're very happy to have you here. Richard is the Program Manager for Infectious Hazard Management at WHO Regional Office for Europe. And the question to you is, WHO Euro is the first region to develop a framework for control and elimination of Mpox. What are the milestones that we should pay attention to in the next 12 to 18 months to measure success? And what are your lessons for other regions based on your process? So we're looking to your experience here, Richard. Over to you.
Okay, thanks, Supriya, for the opportunity to share some experiences from the WHO European region. So, as you say, we've established a goal for control and elimination in the European region. It's a 5-year framework focused on really country-focused approach, with the idea that countries develop national plans around how to achieve control and ultimately interruption of sustained Mpox transmission. As we've been hearing from the various speakers, the key here, we believe, is to move from an outbreak response to a sustained prevention and control program. And again, we believe the key here is linking to broader sexual health initiatives and in particular engaging with the relevant community groups. If we look at the situation here in the European region, it's clearly a different situation to that in the African region. So we don't have an animal reservoir. Before May 2022, we hadn't seen, we believed, sustained local transmission, but we were seeing imported cases, which were being reported from a number of different countries. And clearly, back last year, once we started to look, we found actually a very large outbreak going on across large numbers of countries in our region. And we learned a huge amount through involvement of many different groups investigating these cases and trying to understand what was driving transmission and what could be done to interrupt and reduce transmission. So at the peak last year, we were seeing over 2,500 cases notified in a single week. If we fast forward now 12 months later, so we've now seen just approximately 20 cases being notified from a handful of countries over the past month. So I think it's important that, we try to sort of, what's the main driver behind that reduction in transmission. We think it's a combination of factors. It's clearly associated with the fact that countries have really put in place improved surveillance, case detection, with the associated sort of public health management around those cases and contacts. There's also been a factor around the acquisition of immunity from both natural infection and, at least in some instances, from vaccination programs. But there's also been clearly wider behavioural change in affected communities, at least in the short to medium term, following the real mobilisation of civil society organisations and public awareness campaigns. So we're in a pretty good place at the moment, but what we're really highlighting now with this plan is the fact that we're in for the long haul. We're going to still continue to see importations. We can't relax because we believe there's still a risk of further flare-ups, further outbreaks. In fact, we have seen flare-ups, for example, in London, in France, just in recent weeks. And of course, that's been linked to importations, but also local transmission. We're coming into the active season now with lots of festivals and parties where there is plenty of opportunity for ongoing spread in the affected communities, in the GBMSM community. So we've really kind of a challenge, an ongoing challenge there. So how are we looking to address that within the plan? So the plan's got a number of different components to it, and we've talked around what those are. And those milestones around that are all around the focus on, the keyword here is integration and medium and long-term planning. So it focuses on surveillance, trying to get Mpox in as a nationally notifiable disease. It's on the lab side around ensuring that there's good access to testing, particularly through sexual health services. It's all around having good risk communication in place, as we're seeing at the moment, and that with good links to the CSOs, so that those messages can be got out there to the affected communities. There's also really key important points around access to vaccine for the recommended groups, and we understand that's a challenge, but that does need to happen to ensure that these groups can be protected. And then, of course, there's also the need for ongoing awareness that we don't want Mpox to become established here with an animal reservoir. So the importance of taking a One Health approach and ensuring that we're aware of the potential for spillover into animal reservoirs. So we've got milestones linked to each of those different areas. And then I think if we just then look at what are the lessons learned. Firstly, as we say a lot, the European region is very diverse, both at the national level, but also in terms of the populations here. And I think the key lesson for us around this has been the central role, and this has been said repeatedly, but the key thing of the fact that the engagement with the affected communities has been really central through CSOs and other routes. And that I think has really helped us get to where we are today. But of course, we want that's going to be important as we kind of look ahead. I think the other key aspect that we're learning is the key importance now of integration. That will, we hope, enable access then, readier access to testing and hopefully to vaccines on an ongoing basis. I think another key challenge or lesson learned has been around access to therapeutics for treatment of severe disease. That's not been straightforward in some instances. We need to think how best to tackle that. And I think the final point really is the one on the One Health front, which I think there's potential to neglect that. We need to be aware of the potential for transmission to a new animal reservoir, and we need to be on the front foot for that. But finally, just to say that I think the RCCE work with affected communities and marginalized groups is really important. We need to bear in mind groups such as trans people, sex workers, and so on, who we know can be easily forgotten. But over and out and back to you.
Thanks, Richard. So again, some very important points, the importance of integrating medium and long-term plans as well. And similarities, different situations, different continents, but a lot of similarities, importance of the One Health approach, for example, between the two. Thank you very much. Thanks for joining as well. And with that, we now ask the audience, the participants, for their views. The question to all of you, and please share your views on chat, and I request with Rosamund, my colleagues, Priya and Jiangfeng also to support the moderation here, is what are the most important elements to ensure success of the Mpox control and elimination strategy? And what is the case for prioritizing Mpox for additional investment of resources now? So do share your views. I'll repeat the question. What are the most important elements to ensure success of the Mpox control and elimination strategy? And what is the case for prioritizing Mpox for additional investment of resources now? So do share your views on chat.
Thank you all very much for your participation. We realize you cannot open your camera as this is a webinar. We have 263 participants online right now. We are thrilled that you are all engaging in this. If you have some elements that you want to put in the chat, please do. There's 2 more poll questions coming up, but these 2 are actually just open and free. And I will repeat them again, as Supriya has done. What are the most important elements to ensure success of the Mpox control and elimination strategy? Please use the chat to give us your pointers from your experience and your region of the world. And with all of this, what case can we make to continue to prioritize Mpox for investment of additional resources? Although it looks like we've done collectively a good job in responding to this outbreak, and thank you all, but also the virus is still on the move and outbreaks are still occurring and the risk is still there. So what case can be made for us to continue to encourage governments and other entities to invest resources, funding, personnel, time into responding to this disease when there are so many other competing priorities in the public health sphere? We're seeing a lot of great responses: collaboration, risk communication, mobilization, continuous information sharing, integration, access to diagnostic testing. I will take that across the hall to our folks updating the diagnostic testing guidance today. And at the same time, as we're approaching the end, and while we do the last 2 poll questions, I would like to invite everyone of the panelists to open their cameras. We also have a colleague of Tieblaze. We have Felix Sani, who's been integral to the response from the African region. Felix, please also join us. We have Emily Bass, who's been tremendously supportive and helping to draft the strategy. And we have all our colleagues from EPI-WIN. And we have our interpreters. Thank you for those of you who are listening in other languages. Bonjour, Félix. Félix, if you have any remarks to add, please go ahead while we key up the next poll questions. Félix, over to you. If you wish to speak in French, si vous voulez parler en français, il faut juste nous dire et les interprètes vont s'en occuper.
I don't speak French. Thank you very much.
Oh, I take it back. I'm sorry. Assumptions. You see, assumptions. Mistakes are made with assumptions. Go ahead, Felix.
For now, I don't have any remark. Just quite interesting and educative webinar. And thank you to all the speakers so far. So from the area of Afro, just a little thing I will just chip in is that we are encouraging countries to integrate Mpox into the IDSR, as Dr. Tibble has rightly said, that the third edition has been developed, and we are working with countries to integrate this, so and to other programs available. And I also want to chip in that the region we are working with Nigeria and the DRC, probably Cameroon may be included to do an extended epidemiological investigation, so we'll be able to understand more, particularly the mode of transmission as well as the characterization of Mpox in Africa. So we believe that conducting this kind of investigation will help us more to understand the situation better in Africa, and that will enable us to strengthen our surveillance as well as improve Mpox response in Africa. Thank you. That is from my side. Yeah.
Thank you, Felix. Supriya, over to you for the last two poll questions. We're just running a couple of minutes over time.
Thanks, Rosamond, and thanks, Felix. I'm so glad you could join as well. And thanks to all the speakers and participants for sharing their views, which will all be collected and integrated, reviewed and integrated into the strategy. So my colleague Agnese has put the Slido question up, and before you have the over to Rosamond for the summary.
Thank you. So this second to last question, it is possible to achieve elimination of human-to-human transmission in all contexts with the tools and information available today. There's many elements in that question or statement to say whether you agree or disagree. It is possible to achieve elimination of human-to-human transmission. In which time period someone's asking? That's a very good question. Within 3 months or within 3 years, it would depend on the local epidemiology. Everything depends on the local context. But we have the tools and information today is a statement, whether you agree or disagree. We're actually seeing quite broad spread of the responses from strongly disagreeing. We don't think we can achieve elimination of human-to-human transmission to actually some even more strongly agreeing and right across the board, with most feeling fairly in agreement with the statement, but not everyone. So that's really valuable input. We have a lot of convincing to do. We have a lot of refined and detailed work to do to make sure that we can achieve this ambitious goal. And last question, Supriya.
Over to Agnese for the last question. Yeah, there you go.
The last statement, there's statements more than questions. WHO should advance Mpox control and elimination strategies for all regions and countries. Do you agree or disagree? Strongly disagree or strongly agree? Or not sure what WHO's role is, or not sure what we're doing or if we should continue? You're in the middle. WHO should advance Mpox control and elimination strategies for all regions and countries. As I mentioned earlier, we have 6 regional offices and almost 170 country offices. So WHO supports ministries of health at the national level and supports ministries of health to develop their policies, strategies, and guidance based on what we do at the global level and in the regions. All right. Well, we're seeing 50 responses, upwards of 50 responses. So very, very good engagement with our polls. We still have more than 200 people online. Thank you so much for your very strong participation in this open consultation, this webinar on elimination and control of Mpox. And Supriya, back to you.
Thank you very much, Rosamond. And I echo Rosamond. Thank you, all the participants, for your active participation. Sorry for the repeating words, but it's really been fantastic hearing from you. And Rosamond and her team, I'm sure, will be very happy with all your feedback and will give very important insights. I'd also like to thank, of course, Rosamond for her overview, for, putting this whole thing together, the thoughts, everything. So thank you very much, Rosamond. Thank you to all the panelists. Sylvie and Meg could not be here, but their insights were very important. We still have Andy here, so thank you, Andy. And of course, our regional colleagues who've really been in the thick of things, Theobald and Richard, your experience and what you shared with us is invaluable. So thank you very much. And Felix, I'm very happy you could join and share some of your views with us. I really appreciate it. But there's been a whole lot of people behind this webinar. It's not a webinar, it's an open consultation. And I think that's what makes it so important. The EPI-WIN team, we have Priya, Jungfang, who've been monitoring all your questions and responding to everything on the chat. I have my Agnese sitting right next to me here, who's been doing the Slido questions. And from the Mpox team, there's Emily, I can see, and Kritika. Please do put your cameras on, everyone. And the interpreters, Carla, Damian, Tazara, Laura, Roberta, and Javi, I think. And who did I miss? I missed one interpreter. I'm so sorry, but thank you to everyone for making this a success. And, the implications of this will be beyond today when we have it all put together in a great strategy. And with this, I'd like to also let you know that next week we will be having another webinar on One Health and with a country perspective. And on 12th July, we will be having a webinar, EPI-WIN webinar on respiratory diseases, pandemic-prone respiratory diseases. So I hope we can welcome you again in the next 2 weeks on Wednesdays and look forward to your support. Thanks to all of you and see you soon. Bye.
Thank you, everyone.
Thank you.